Hi, listeners. Just before we get to this month's episode of Ask the Expert with Amy Board, I have an important announcement to bring you from Bayer, who makes Ask the Expert possible. So Bayer on Friday announced a voluntary recall of 2 lots of Cogenate FS on Friday, July 19th, for those who aren't listening in real time. So I'm going to just quickly read the medical advisory that came out from the National Hemophilia Foundation. Both NHF and HFA on Friday put out announcements about this recall. So I'm going to read NHF's. There's a link in the program notes. So if this pertains to you, or if you're a community leader and you have to help disseminate, or you are inclined to help disseminate this information, you can click the program notes to read on. Bayer has announced a recall of 2 lots of Cogenate FS 2000 IU vials. Within these 2 lots, there were certain vials labeled as Cogenate FS, but actually contain Jivi. This recall is only in the United States, where affected products were distributed. Below are the affected lots that were distributed from February 5th, 2019 to July 15th, 2019. Again, both Cogenate FS 2000 IU lots, one lot number 27118RK, the other 27119CG. Again, link in the program notes if you want to double check those. Patients in possessions of any vials from either of these lots should immediately stop using the product and contact their physician and contact their product distributor or pharmacy to return the affected product. If a healthcare provider or patient has any questions, they are encouraged to call Bayer's Medical Communications Hotline at 1-888-84-BAYER. That's 1-888-84-22-937. Importantly, vials of Cogenate FS that are not associated with the affected lot numbers, again, 27118RK and 27119CG, are not impacted and can continue to be used. For any physicians listening, please distribute this information to all providers in your area who treat patients with hemophilia. For any chapters and leadership who are listening, please distribute this information to your membership. And lastly, you can sign up for the patient notification system to be notified directly about the latest recall or withdrawal of recombinant or plasma products. This system is confidential and time sensitive. It is administered by an independent third-party organization and is free of charge. So to enroll in the PNS, the Patient Notification System, please call 888-UPDATE-U, just the letter U, update U, 888-UPDATE, the letter U, or go online, patientnotificationsystem.org. So that's it. Those 2 lots of Cogenate. There's a voluntary recall. Again, click the link in the program notes for if you want to read on or if you want to pass this information on to anyone to whom it would be of interest. And appreciate Bayer's efforts to get this information out as quickly as possible. Also, as I mentioned right at the top, the Ask the Expert podcast is brought to you by Bayer and the good people at Living with Hemophilia, the online community brought to you by Bayer. Living with Hemophilia is the destination of choice for a plethora of useful info, like medical and non-medical tips, helpful advice, information on programs for all ages and stages, leadership opportunities and initiatives, sewing patterns, and videos. The best videos. And because it's on the internet, it's easy to find. Simply type livingwithhemophilia.com into your search bar, and you're there. Thank you, internet. Join Bayer's community of fellow hemophilia patients, caregivers, and advocates as we put the live in Living with Hemophilia. The live has an E and living doesn't, so I don't know. What are your plans for that, Bayer? Huh? I ask the hard questions. You can even like us on Facebook. That's even better because you can use emojis on the Facebook page. You receive all the latest updates. Check out Living with Hemophilia, and before you wish happy birthday to that friend from 3rd grade or share a funny meme about cats and Mondays, head over to Facebook and like Bayer's Living with Hemophilia page. You'll be glad you did. And now please enjoy Ask the Expert with your host, Amy Board.
Welcome to another episode of Ask the Expert. I am your host, Amy Board, and today we have a good one. Today we are discussing joint health, physical activity, and treatment adherence, the trifecta, if you will, the bleeding disorder trifecta. If you have a bleeding disorder, you are asked, I believe, on the regular, how many bleeds you have had a year and how that translates into the health of your joints. It's a very interesting topic. It is becoming a larger national topic as we really are striving for the most minimal amount of bleeding into those joints as possible. But today we're really going to talk about, in particular, how these 3 areas of hemophilia care are connected joint health, treatment adherence, and physical activity. How do they complement one another? Can you have one without the other? It is going to be a fantastic conversation. We have a well-known physical therapist on the show today, so we're excited to get into that. But hey, before we get into the good stuff, I have to give a shout out to the Bloodstream podcast this month. Holy smokes, they have great stuff. If you haven't listened to Bloodstream this month, you got to do it. You got to put it on your list. They're breaking down several things that I think are really great. There was an article that was released recently, actually, in the last couple of weeks. Medicare actually is considering covering acupuncture for chronic low back pain. And you would think, how does that whittle down to the hemophilia community? It has nothing to do with the bleeding disorder community. But if you think about it, chronic pain is something that we are very aware of and something that we deal with in our community. And having a federal program like Medicare cover an alternate therapy like acupuncture, that is a big deal. A lot of trends seem to shift from those bigger federal programs like Medicare and Medicaid. So it's something to keep an eye on. And Natalie and Patrick have a great conversation about it this month, so make sure to check it out. As well as another article that has come out recently that Patrick discusses on the comment segment about non-factor replacement therapies. There are a bunch of non-factor replacement therapies in clinical trials right now, and he gives us a bit of an update. So it's great. It's great. It's great. It's a wonderful, informative listen as always, so make sure to check that out. Speaking of this podcast, again, I ask every month, and I will continue to ask every month. I would love your questions. I would love your thoughts for future podcast topics and experts. Of course, you can find me at Twitter. My handle is @Bordeaux87. And our email here is mailbag@bloodstreammedia.com, so I would love to hear from you. And of course, I want to give a special thanks to Bayer Pharmaceuticals for sponsoring Ask the Expert. Without Bayer's support, conversations like the one I'm going to have today wouldn't happen, so we are so eternally grateful. So today's expert is Cindy Bailey. Cindy is the director of physical therapy at the Los Angeles Orthopaedic Institute for Children. She has a background in sports orthopedics. She's been a hemophilia PT for a long time. She's a part of the national conversation, and she is going to join us about the trifecta: joint health, treatment adherence, and physical activity. Some of the things that we get into are really wonderful, and they're universal. I really think they're universal. Is an active joint actually a healthy joint? Are we supposed to sit around and just let our joints stay still, or are we supposed to get up and move? How important is physical activity for our joint health? She describes what a healthy joint actually is, and maybe it's not exactly what you think. I was kind of shocked by the answer. I thought I know all, and I guess I don't. But anyway, it's fantastic. She also walks us through how one bleed can create damage. Not just several bleeds, but one bleed can create damage. And some of the technology that is being used today are helping clinicians prevent bleeding early and earlier. So it's a really fantastic conversation. It's a wonderful episode, and I am so glad you are joining us. So grab a cup of coffee and let's have ourselves a conversation. I am your host, Amy Board, and welcome to episode 29, or our Does Treatment Adherence Mean Healthy Joints? Episode of the Ask the Expert podcast. I'm joined today by Cindy Bailey, the Director of Physical Therapy at the Los Angeles Orthopaedic Institute for Children. She represents the Western States in the National Hemophilia Foundation's Physical Therapy Working Group and is currently clinical faculty at Mount St. Helens Physical Therapy Doctorate Program. Cindy, welcome to the Ask the Expert podcast. Truth be told, you are my first HTC physical therapist I've had on the show, and I'm so thrilled to have you.
Well, thank you, Amy. It's wonderful to be here. We love giving any information we possibly can.
You know, I'd love to start actually by asking about that physical therapy working group. I don't think the majority of the community understands that these working groups even exist and how they contribute to the community and the clinical field of bleeding disorders. So I just wanted to ask you a little bit, what does that working group focus on? How long has it been in place? What does it provide to the community?
Certainly. The working group is put in place by the National Hemophilia Foundation under the MASAC guidelines and the MASAC committee. And MASAC stands for the Medical and Scientific Advisory Council. So within the NHF, they have a council of scientific and medical advisors that then have made various committees within the professions that work in hemophilia. So there's a nursing working group and a physician's working group, physical therapy working group, social work, pharmacy, and there are a couple other subgroups, and also a patient group which is represented. And within those subgroups, which are the PT working group or the nurses working group, each one of those groups are divided into regions of the country. So we try to get representation of all of the providers in the country, but also through the providers, we also try to get representation of each of problems that patients in those specific areas of the country may be having. So it's a regional representation of what's going on in the communities around the country, not only by, again, there are patient groups there as well, so not only represented by patients, but also by the providers bringing in those problems and trying to resolve them. And then we also try to do an output of information to our regions so that it can be disseminated through the therapists or nurses or social workers or physicians down to the community level, to the associations that are the foundations, that are community support, and actually contact the individual client or patient care. So it's a regional representative that then works on these targeted groups. And we do a lot of outreach to clinicians. So we will contact the clinicians in our area for physical therapy and say, we're writing a new guideline for physical therapy after a total knee replacement. So can everybody send in your programs, and we can try to consolidate and pick out what's uniform that everybody does, and then those things that some people do and some people don't, we might call and have questions, and then narrow it down to a nice guideline that's simply a suggestive guideline. It's not something that everyone has to follow per se, but it's a guideline for professionals that have not been familiar with hemophilia. Maybe they're new to the treating discipline. And so they will then have a guideline to kind of go off of and vary it based on their patient needs. So we do community outreach on a regional basis. We do guideline preparation, and then we also do guideline review, because some of those guidelines have been there for years, and we want to make sure they're updated. So each working group also does guideline updates, and then we also have a section where we try to give references so that patients and their families don't have to look up what is the newest guidelines for play it safe. What are the new guidelines for how much activity your child should be involved in if they're at a certain level of either mild, moderate, or severe, or something like that? Are there new guidelines based on radionuclide synovectomy and activity afterwards? So we try to update our guidelines, create new guidelines, and kind of really have things in place so that the patient and the other providers can look at our PT working group and get the newest information that we possibly have.
Wow. Is that a standard practice in other chronic disease organizations and clinical field?
No, it's not. And it's really something that the bleeding community should be very proud of. And we take on these assignments and these projects probably much more so than other communities. My basis of preparation for my physical therapy, I'm a sports specialist. That's where I came from. And so with that, I've been associated with many different groups in different sports associations, as well as in the physical therapy working groups at a national level in the general physical therapy association. And many people look at the bleeding community for a type of framework that they could also work their chronic diseases, arthritis, rheumatology, different types of chronic pain syndromes, chronic illnesses, where they can make a framework for how their working groups can work. So bleeding disorders actually has come to the forefront of designing those types of networks for the profession and the professionals, as well as the patients and the communities. So we should be really proud of that, because we've kind of been around as working groups kind of before a lot of the other groups came to think, oh, this is a good idea. We can not only give professional education to other providers, but we can also give education to the communities. Yeah.
I think sometimes the community thinks that we're so, I think as a patient, we can feel so different, and people don't understand, the language that we use. And just to hear that on a national level, that we have created something clinically for our community, I think that's kind of something that we can hang our hat on. I like that.
Absolutely. Even the CDC representatives, when they come out to visit with us, are very complimentary that the bleeding community has been very proactive in setting up the comprehensive centers and providing comprehensive care for their patients. Yeah.
You spoke a little bit about your background, that you came from a sports background, but how did you get connected to the hemophilia community? And tell us a little bit more about yourself.
Well, that was actually very interesting and funny. I was I was actually hired through the physical therapy school at the University of Southern California for the first doctorate degree program in physical therapy. We rolled over from bachelor's to master's and then master's to doctorate. So now all of the physical therapists coming out of school will have their doctorate degrees in the future. And so as we were doing that years ago, about 20-something years ago, the University of Southern California contacted some of us and said, we want to develop fellowship programs. And my particular area was orthopedics and sports. And so they hired me to actually work at Los Angeles Orthopaedic Hospital, which has since changed its name to Los Angeles Orthopaedic Institute for Children. And they wanted to have someone that had experience in making fellowships and internships, residencies. So it would mimic a physician's education, because when we would tell physicians, well, this person is at a residency level, what that used to mean to us was that was the most advanced physical therapist training that we had, and it was at what they would consider a postdoctorate level training. But it didn't mean that to the doctors. What it meant to the doctors was, oh, you're just out of school and now you're doing some more training because that's what their model was. So we have now gone back to the drawing board and tried to mimic physician education in the years of study and whatnot, so that when we tell a physician this is a doctorate level physical therapist with a residency or with a fellowship, then they know how much education that is, so that they can tell, is that a specialist, is it not a specialist, something like that. And so I was hired to implement some of those educational programs, but as my hire, I was actually placed at Los Angeles Orthopaedic in order to manage the practice here. And on my second day of work, all of those of us who know Carol Casper, Dr. Casper was here as the main hematologist at the time, and I got a letter from her on the second day I was here, and it said, well, we are usually accustomed to our head of physical therapy attending our hemophilia rounds meetings. Hopefully we will see you in the future. And I went, oh my goodness, what have I done? And so I went to administration and I said, oh no, who is this and what kind of a meeting is that? And do I need to go? And I would be happy to go. I just don't know what it is. So I knew what hemophilia was, but I didn't know that, they had rounds and these weekly meetings and all sorts of things. So administration very quickly took me up to the hemophilia treatment center and introduced me to Dr. Casper, who is just an angel. She's wonderful. And so that's how I was introduced to hemophilia. And since then, it has become an absolute love. And the patient population is just so unique that it brings so many challenges as a professional. It really keeps your mind going, and how can we help this population, and how can they help us? Because they help us learn every day in orthopedics and sports, and how we can take their experiences and what has happened to their joints with bleeds, because it doesn't matter whether you have a bleed or a joint injury because of a hemophilic bleed, or whether it's because of a sports injury, or you were in a car accident, or you fell and scraped your knee. If you have blood in the joint, you have blood in the joint. So it doesn't really matter why and how it got there. The fact is it's there. And so they have taught us so much in being able to treat them, in how now we can extrapolate that information and use it on our general orthopedic population, as well as use the general orthopedic population information in the bleeding disorder community. So it's really a wonderful opportunity to use the educational knowledge both ways.
Oh, I have not heard that. I just love that. I have not heard that the hemophilia community has kind of informed, general sports orthopedic care in a way. Oh, that's
absolutely. Blood in a joint is blood in a joint. I mean, like say how it got there, we don't care. It's still going to destroy the cartilage and the synovial lining if we don't get it out.
Yeah. Well, going into the nitty gritty, today, I was sparked by an article that I just randomly saw on Twitter, classic Twitter clicking, and just wanted to discuss a little bit the unique connection between joint health and physical activity and adherence, treatment adherence, specifically when you have a bleeding disorder. And just to kind of kick us off, can you explain how they're so intimately connected, joint health, adherence, and physical activity?
Yes. Well, first of all, you need to know that how intimately related just joint health and activity are, let alone the adherence portion of it. But joint health and activity are very intimately related in that we know through studies from Dr. Luck and Dr. Silva, some of the European physicians, that if you have better musculature, you will have fewer joint bleeds, whether you are a severe, a moderate, or a mild. If you have better musculature around the joints, you will have fewer bleeds. And that makes complete sense because we know that even in a normal population that does not have hemophilia or a bleeding disorder, if they have better musculature, their biomechanics and the movement of that joint are much better and less unstable. So if we are stable and the joint is moving correctly, it's not going to pinch the lining of the joint. So if we're weaker and our joints are kind of wobbly, we will pinch the lining of the joint more often. And the lining of the joint, or the synovium, the synovial lining, is what gets inflamed and continues to bleed. And it's just like biting your cheek. That's a mucous membrane, very much like the lining of your joint. So if you bite your cheek, like 3 or 4 chews later, guess what? It's swollen in that area, and you bite it again. Yeah. And that's what happens when you pinch the synovium inside the joint. It swells in that spot, starts to bleed a little bit and get irritated. And so then when you bend the knee again, or the elbow or the ankle, you pinch it again. And it just continues that cycle. Where if we have good musculature and it guides that pattern of movement more stably, then you're probably going to have you will have less chance of pinching that joint lining. So just to have better musculature leads to much healthier joints. So then when we talk about adherence to your prophylaxis, when patients understand the relationship of healthy joints, healthy musculature, fewer bleeds, then they start to go, oh, okay, well, if I want better musculature, then maybe I should get in the gym more, which is what we would prescribe as a physical therapist, certainly, would be more activity and more gym. Yeah, we like the gym rats. So we would say, okay, so let's get you in the weight room if you're more than over 14 and past your second growth spurt. So let's get you into the gym. Let's get you doing some light weights and some endurance and some good training. But in order to do that, you need to match it with your prophylaxis days. And so it becomes a thing of, and then once they start to get healthier and they get more fit and more musculature, then it becomes a thing, well, I like to do this. This is fun. I feel better when I do this. So when we're trying to make these healthy joints, we try to match it with prophylaxis, so it becomes a marriage of, if you're going to be more active, you need to do your prophylaxis. So it becomes that type of an environment, and then they feel better and they're more willing to do it. And then that's when the adherence comes in.
So this topic of joint health is starting to become, it's not starting, I shouldn't say that. It just seems like there has been a slow build that we're talking about it a lot. A lot of education is coming out about it. There was a CDC grant, I think, to NHF, and I think a little bit of HFA to do a joint health survey. NHF is coming out with more and more joint health programming. Where is this coming from? Where is the national conversation specifically around joint health coming from?
Several places, and one of the places is the fact that there has been a lot of research saying that better musculature will, in the long run, give us better joints and fewer bleeds. The next place was Dr. Marilyn Manco Johnson's research study in 2007-2008 that said better prophylaxis will always also give us better joints in the long run. So then when you carry those two forward, we get, okay, if we're doing prophylaxis and we're doing the exercise, then we can have exponentially even a healthier joint. So while we're trying to match as kids get a little bit more prophylaxis availability, so now most folks in the United States, if they have the want to be on prophylaxis, hopefully they're in an environment where they can achieve that. And with insurance companies and just those types of situations. So hopefully they'll be able to access prophylaxis for themselves or their family. And in that way they can be more active, have healthier joints. And so the conversation has kind of come about both from the studies that say if you have better musculature, you'll have healthier joints, fewer bleeds, and then, well, if you prophylax, you'll have healthier joints and fewer bleeds. And then by blending those together in the last 10 years or so, now we're getting this conversation of, okay, well, if we prophylax, we can work harder at becoming more fit, and then that will give us better joints and better health. And the children of the future, rather than saying, okay, no, be careful, we don't want you to really jump around or get, you might get injured, we're saying we want you to be healthy, do organized sports, do organized type activities, or at least supervised activities so that we know that they're safe. But if we're pushing your limits, because that's what you have to do to get in shape, let's go ahead and prophylax on those days. So it's becoming more and more of I'm happy to say it, but it's a little bit hesitant, more and more of a sports kind of, let's go ahead and do those early activities, because the better musculature, the better joints, and that'll give you better musculature as a child, which will grow into better musculature as an adult. Hello.
Cindy, I am so sorry. My phone dropped the call.
I know. I was like, okay, I talked too long.
Nope. No. I hope we leave this in. Funny. Oh, no. Fantastic. This next question, actually, to continue, this next question might get into the weeds a little bit, but I am interested. How do we measure joint health? I mean, again, to me, it's like, a healthy joint is one that can move freely and has very little pain. But how do we measure joint health?
There are several subjective measures. With different questionnaires, we can use the HAL, which is the Hemophilia Activity Score, and we can use the FISH, and they're all like abbreviations and whatnot. But so that's how we measure it from a patient standpoint, is through questionnaires. Like, how active can you be? How active would you like to be? Do those two things match? I mean, are you as active as you want to be, or do certain things limit you? So that's the first way, is from the patient's point of view. And then there are several objective ways. Those would be subjective. It's what the patient thinks and wants. And then objectively is what we measure. So objective measures of a healthy joint are, is there swelling? Is there bogginess of the synovium? Can we see the landmarks of the bones? Or is there a little bit of a puff covering it? And does it make noise when you move it, which even in the non-hemophilic population, after the age of 25 or 30, most of our joints make noise when we move them. And that's okay, but does it hurt if it crackles or pops? And that's when we get into, okay, that's not normal if it hurts. So we look at at the overall joint health of what it looks like. Is it measurable for that swelling or puffiness that it's different from the other side? How long has it been there? Is it just like, oh, I twisted my ankle, it was there for a week and it went away? Well, so would everyone else's, so that's kind of normal. Or did it stay for 4 months? That's not okay. And then we look at, is the muscle the same, or from non-use of that side because of an injury, have you had atrophy? So we look at atrophy. It's measurable. It's something that is objective that we can quantify. And then we also look at the range of motion, like how far do those joints move, and is that equal to the other side? And if the other side is also limited, is it equal to, or how far off is it from the folks who don't have hemophilia? And then we also look at the amount of pain a person is having and how strong they are. Even though a muscle isn't robust, it doesn't mean it's not strong. And we see this most often in patients without hemophilia as well as patients with hemophilia who have had knee surgeries. And if you put a tourniquet on and you turn that tourniquet up in order to slow the blood flow to a knee, so to speak, if you were using that as an example, if you were having a knee surgery and you slow the blood flow to the knee during the surgery with a tourniquet, then you take the tourniquet down and everything is fine. They stitch you up and off you go. But we now know that the tourniquet time up is correlated with muscle atrophy. And so even if you were an athlete with no other complications in your life and you had an ACL surgery, that side will probably always be a little bit less robust muscularly. It won't be as defined as the other side. However, it can be just as strong. And so strength does not necessarily mean girth. So we do note the atrophy, but we also note the strength. So how strong is that limb? So the objective measures are going to be our swelling, our crepitus and noisiness, and does that create pain with it, or is it just noise? Our muscle girth and our muscle bulk, as well as our range of motion and our strength. So those are our objective measures, and those all get put into a measurement tool called the Hemophilia Joint Score. So all of that compiled all together is the Hemophilia Joint Health Score. And then there are other ways to objectify it nowadays, where we are just coming into a new era, which is just phenomenal, and the use of imaging ultrasound for musculoskeletal ultrasound. We can actually look at the cartilage of a joint and determine its health. We can say the cartilage is wearing away, the cartilage is good, the cartilage is, it's having a little bit of difficulty. There's been some bleeds in there, but it's still pretty good, and the bone should be really healthy underneath it. We can see changes before they can be seen on X-ray. So it's like looking at the baby with the baby ultrasounds. We get to see all that soft tissue and all that cartilage. So it's a wonderful technique and a wonderful imaging tool to use, especially for pediatrics, for childhood, because they can see when cartilage is being damaged, not just when bone is being damaged, because your cartilage is what will be damaged by the bleeds and the synovium. The bone deterioration comes much, much later. So if we can educate the parents and the kids when their joint health is being affected early on by using the HJHS and the ultrasound imaging, then we can get the parents and the children to actually look at their own images and go, this is not a model that we're getting from an education company. This is you. And that really seems to be educationally very, it's changed a lot of minds in the parents going, oh, that is my child's ankle that's had 2 bleeds. The other side hasn't had any. And look at the difference. It's like, after only 1 or 2 bleeds.
After 1 or 2 bleeds, you can see a difference.
Absolutely. Yeah,
Wow.
and that's the critical point here is we can actually show the parents the objective changes, and then and let them know that up until the age of 8, 10, 11 years old, their body can repair some of that damage.
Huh.
So up to the age of around 8 to 11 years old, their body can repair the damage of cartilage that is being a little bit damaged by a bleed in the area. So we want to get that information to the parents and say, now that we know that your child is affected by hemophilia or a bleeding disorder, and we know that they have had a bleed into this joint because we're seeing these changes of cartilage thinning and synovial thickening, now we need to get them on prophylaxis and keep them there so that this joint has time to recover before the age of 10, when the cartilage is basically going to be what they're going to have for the rest of their life. So we can really make those changes if we can detect them early on. And that really has made the difference in a lot of the families being much more compliant.
Interesting.
Yeah.
So to move it, I mean, this is going so naturally, to move the conversation over to adherence. I mean, prescribed treatment regimens obviously can increase joint health. And again, you just spoke to it. Why is adherence so critically important to stopping, obviously, bleeds and the health of your joints?
Right. So when you have this beautiful, pristine cartilage that we call hyaline cartilage, it has little holes in it if you look at it microscopically, and it's mostly water. But the little holes, that it's held down by these fibers it's just pure collagen, and it holds down the water onto the surface of the bone, and so it looks like this white glistening surface. And it has little holes in it. It's porous like a sponge, so that every time you step down, you squish the fluid out. And then when you lift up your body weight, it drinks the fluid back in, just like a sponge in the sink. And when it does that, that beautiful fluid inside your joint is synovial fluid, and so it drinks in that synovial fluid, which also has nutrition in it. So that's how the end of your bone gets nutrition after you seal off your growth plates, etc. But during growth, it's just how you get part of the nutrition to your bone and to the cartilage. Well, unfortunately for us, our bodies love those little teeny holes in the hyaline cartilage, love iron. So if you have a bleed, and as the red blood cell breaks down, that iron starts to plug up those little holes in the cartilage. And as they do that, that's when the cartilage starts to break down, and the bone behind it doesn't get as much nutrition either, and it starts to break down. So when we're talking about how important is it to prophylax and to stay adherent to your regimen, it is incredibly important, because even after one bleed, you can start to have some of that damage with those holes plugged up and the synovium irritated by the blood, and then you don't get as much nutrition to those structures, and they won't properly grow and properly cover the ends of the bone, and you can start getting arthritis at a very, very young age, even with one bleed. Now, our hope is that that a young person's body will recover and they will make normal cartilage if they're under the age of 10 or 12. But if we can have them not have that bleed by putting them on prophylaxis and having them stay on prophylaxis, or if they did have a bleed, and we can educate the family and the patient, this is really important, and this is why. And let's take objective measures on the HJHS, range of motion. Let's take objective measures on an ultrasound image or any other objective signs that the clinician has available to them, so that we can see these very, very early signs of change. And then we know that if we adhere to our prophylaxis regimen, the child can recover that and then stay healthy, stay on that regimen so that they won't damage those areas again. So the adherence is incredibly important, because even if they went, oh, you know what, I'm going on a basketball trip, I'm going on a camp out, I'm going wherever, I don't want to take all that stuff with me, and I don't want to infuse and take time, and they just have one bleed, it starts to plug up those holes, which will create some deterioration. So adherence is incredibly important, because any blood in the joint will start deterioration.
Unbelievable. Let's talk about mild and moderate patients. If they are on demand, how do you guys look at that? How do you treat that as kids up to the ages of 8? How do you look at mild and moderate patients differently?
Mild and moderate patients, we just try to. It's really scary because it's actually kind of easier to treat the severe because they know there's an issue and they really stay on board and they really, once they have the education of, oh my, this is my problem. Okay, I have to really do this. With the mild and moderate, sometimes they're a little more relaxed about it. And we're like, no, you really have to stay on top of this. If you have something that feels like, a warm bubbly in your joint, and you feel like something is warm to the touch and it's swelling and it's not going down the way it usually does, you need to call your treatment center. You need to get on top of it right now because they will also have the same changes any of us would, even if, again, if it were someone without hemophilia or a bleeding disorder, but they were in a car accident. If that blood isn't going away as it should, any of us are going to have those same problems. So to educate the mild and the moderate is sometimes very difficult because they don't see the problem as often and they don't feel what it feels like as much, so they're not as familiar with it. So we really have to stay on their education. If this happens, you've got to get to your hemophilia treatment center so that they can give you all of the ways we have to evacuate the blood from that joint, and we can get you on some type of a program. And if you are going to do, performance martial arts, by that I mean like the routines, not necessarily competition, but the routines that you do to go up one belt to another. It's kind of like positions, and you show your positions and your different moves, but you don't necessarily hit people. You don't necessarily hit items. So that wouldn't necessarily be good for a patient with a bleeding disorder. But we do have a lot of them in martial arts because it's awesome for balance and for movement and stretching and things like that. But they're in the side where you're just performing to get your belt. You're not fighting. You're not competing with another person. But say they do have, because it's very, very ultimate stretching in some positions, before you might go to one of your martial arts classes, how about if you prophylax just on those days? Or maybe you're fine for class, but when you go to perform for your belt, then you need to prophylax on those days. So with the milds and the moderates, we try to kind of set them up to say, well, most of the time you're going to be fine. But if you know you're going to do something that's specifically difficult or very physically demanding, let's get you on some type of a schedule for that and find something that will work for you for that, because we don't want any blood in the joint. So let's see if we can do something for you. So that's the route that we would go with a mild or a moderate, is just educating, and saying, it's going to be more difficult to manage sometimes with you because you don't know what it feels like and you forget. And so you have that feeling, but you think, it's just a sprained ankle. No big deal. Everybody has sprained ankles. But for you, if it doesn't start resolving in 2 or 3 days, that's a big deal, and you need to get in. You need to see us about it. So that's the way we would handle the mild and moderates, is more so with just saying, you probably are going to be fine most of the time, but if something is out of the ordinary, you need to contact your HTC because we need to have no bleeds in this joint. Yeah.
This how often are patients actually adherent? You're dealing with behavior and life, actual life. I know it's a struggle for people that have chronic disease. I have to give my dog seizure medication like 3 times a day, and sometimes it's hard. How often are people, adherent, and what are the barriers to that?
I don't really have a study for the Americans in the Western United States, which they seem to be a little more health conscious than sometimes other folks. And then sometimes they're not. I mean, if you go into the more surfer, skateboard, skier folks, they're more relaxed than a lot of people. And so we have both spectrums. We have people that are on the vegan end and vegetarian that are very, very into their body and their health and yoga. And then we have those folks who are going, yeah, whatever, hey. So we kind of get both sides of the spectrum here in California and the West Coast. But in any case, the adherence rates, I think, are different for different populations. And we just try to do the best we can. But I don't have a study for the U.S. specifically in what our adherence rates are for the different age groups.
Going back a little bit to some of the bulk of the first things that you said, one of my favorite quotes when I was working in Colorado with Sharon Funk and with Dr. Manko Johnson was they actively believed that a healthy joint is an active joint. And we always promoted, safe and good physical activity. And I just kind of wanted to ask you, is that true? Is a healthy joint actually an active joint?
Absolutely. And that would go back to the studies done with the orthopedic folks who have done how does musculature and more musculature affect joint health. And I'm just really lucky that I work at Los Angeles Orthopaedic because Dr. Luck is here and Dr. Silva, and they've done tons of research, and a part of it was on that. And they showed, and others in Europe have done studies that have shown the same thing, that the better musculature you have, which would be an active joint, you have to be active and put that joint through range of motion and try to max out that muscle at least 2 to 3 times a week in order for it to gain strength. So we know that if you're gaining muscle bulk, you're gaining motion and activity. So we know those are active joints, and those are healthier joints. So a healthier joint, an active joint, is absolutely a healthier joint because it's getting more musculature around it, and that's going to allow it to move in a more correct alignment and be more stable. Now, although I'm not aware of any recent studies showing percentages of adherence in the United States, you had brought to my attention an article from Europe, from Italy, where they showed adherence rates. And their adherence rates, I think, are better than ours, I have to say. I think it probably... I know. I think it probably goes to the Americans are a little bit more relaxed about things. But their adherence rates are in the 83 to 80, 78%, and with people who are active. So if they're active, their adherence rate to their prophylaxis is around the 83 to 78% range. And if they are prophylactically adhering to their regimen, then they are more active. And if they're more active, they're adhering to their, it went both ways. The active people were more adherent to their prophylaxis, and the people who were adherent to their prophylaxis were more active. But that leads to the question of human behavior, which comes first, the chicken or the egg? So were these people, exactly, did they want to be more active, and they're saying to themselves, well, if I want to be more active, I have to stay on my prophylaxis? Or are they people saying, well, since I'm prophylaxing, hey, now I can be more active? And so it's like we don't know which came first, but we do know that people who are more adherent are more active, and people who are more active are more adherent. Yeah.
Fantastic. Cindy, thank you so much for joining me today. I loved it. And also, I just wanted to say thank you for agreeing with Dr. Manko Johnson and Sharon. I would have been in trouble if you didn't agree, I guess.
Absolutely. Well, they do fantastic work there, so I would certainly be in trouble too.
We all would be in trouble.
Exactly.
Thank you again for your information today, and hopefully we can talk to you soon.
Okay. Thanks, Amy.
And that is all for episode 29 of the Ask the Expert podcast series. We'll be back next month with another expert interview.
Have you checked out Living with Hemophilia yet? If you have, kudos to you. Not only are you eager to join the exciting community of discourse and helpful information, you're also a keen listener and patron of the arts. But if you haven't taken a swim through livingwithhemophilia.com, take a moment to pull it up on the ol' internet. I think you'll love it. helpful content, relevant updates, and, most of all, a bunch of people going through the same things you are. It's a growing part of the online Living with Hemophilia community, brought together by the good people at Bayer. Also, put it on your Facebook to-do list. Hit the like button on the Living with Hemophilia Facebook page. It's a good alternative to looking at the slideshow of your neighbor's recent foot surgery. I mean, unless you're into that sort of thing. Living with Hemophilia from Bayer. Check it out.
Bloodstreammedia.com is your one-stop shop for all of Bloodstream Media's podcasts for the bleeding disorder community.
Once on bloodstreammedia.com, don't forget to follow the links to subscribe to the Bloodstream podcast, Ask the Expert podcast, the Powering Through podcast, and the Bloodline podcast on iTunes, SoundCloud, or wherever you listen to podcasts.
Have an idea for a future episode of Ask the Expert? Have a question that you would like to hear an expert answer?
Email us at mailbag@bloodstreammedia.com. You'll also find Bloodstream Media on facebook.com/bloodstreammedia and on Twitter @bloodstreaminfo.
This episode of Ask the Expert was written by Amy Board.
Produced by Patrick James Lynch.
Rob Bradford.
Joshua Sterling Bragg.
Avra Friedman.
And Colby Crow.
Artwork by Katie Wright Mead.
And Ryan Geelan.
And the Ask the Expert podcast is edited by Allison Stoney.
I'm your host, Amy Board, and until next time, embrace that mystery and fear of life. You are not alone.